Thank you, Steve. I'd like to thank the organizing committee for the opportunity to present this work here today. And as always, this has been a great meeting and a great opportunity to see a lot of friends and make new friends. And I'm already looking forward to next year's meeting. We have no disclosures. As you saw the title, why is readmission important to analyze the reasons for readmission and the consequences of readmission. Number one, readmission is expensive, and several studies have demonstrated that it's more expensive to readmit a patient than to keep a patient for an extra 1, 2, or 3 days in the hospital. Number two, readmission is associated with morbidity and mortality. That has already been documented. And readmission can lead to reduced reimbursement, and we need to be cognizant of this. For this study, we analyzed data from the American College of Surgeons NSQIP from 2012 to 2014. This database tracks data that is not available from the SDS. The esophagectomy cases were identified by CPT codes and stratified into cancer and non-cancer cases. Preoperative, intraoperative, and post-op variables were compared. The new NSQIP tracks approximately 21 important variables, including readmission. The readmission cases were analyzed using a model, Cox regression model, to analyze the results of the study. The NSQIP database tracks the postoperative events within 30 days from surgery, including the readmission. A person that is discharged on post-op day 15 will have 15 days at risk, versus a person that is discharged on post-op day 2, this patient will have 28 days at risk. One of the drawbacks of this is that a patient that has complications and stays in the hospital for more than 30 days does not fit into this category. So this is one of the drawbacks of the study. We identified 3,547 esophagectomies, and of note, 46% were Ivor Lewis, about a quarter were transhiatal, and 16% three-field, and thoracoabdominal 10%. Overall, approximately 45% of all the esophagectomies were performed by cardiothoracic and vascular surgeons, and 55% were performed by general surgeons or surgical oncologists. Major morbidity was identified in approximately a third of the cases overall, and 57% amongst those readmitted. The most important comorbidities included thromboembolism, pneumonia, reintubation, failure to wean from the ventilator, and other complications. However, variables that were associated with readmission were deep wound infection, which is defined an infection above the fascia, organ space infection, which is technically a leak, pneumonia, venous thromboembolism, and sepsis. Based on this, we performed a readmission score. And these were weighted to arrive at a risk score. Then we analyzed the patients according to the number of risk factors that they had in terms of the correlation with readmission. Patients that had 0 of these risk factors had a low readmission rate, less than 10%. As opposed to patients with a score of 2, they had almost a 30% readmission rate. And patients with a score of 4 had up to about 40% readmission rate. What we found is that surgeon specialty, cancer diagnosis, and type of esophagectomy did not influence readmission rates. Postoperative complications were the primary drivers for readmission, and the most important complications were either a leak, sepsis, venous thromboembolism, and pneumonia. Post-discharge resources, such as home health, early clinic visits, and phone screens should be focused on the patients at high risk for readmission. Thank you very much.